The reason I wanted to give this lecture is that there could be a lot of terms that are being used sporadically with regard to, again, the business aspect or the financial aspect, measurement of value, et cetera, in the spine world that we may not all be familiar with. This is basically going to be a primer for these types of terms that you see here: utility, QALY, daily, et cetera. One of the things I liked when I went to medical school, I wouldn't have to think too much about these kinds of business aspects, and of course our world is changing, and so we have to become more familiar with the language that's being used. I kind of feel like this sometimes when I'm looking at this stuff, though.
Isn't it true that the jobs provided by the bill will create up to $150 billion in increased production? Using Walter Heller's figure that for every 1% unemployed, there is a resulting $37 billion loss in GNP. Now, at the present rate of taxation on GNP of 39%, doesn't this come to about the same $60 billion in increased revenue?
It was my understanding that there would be no math.
So I'm probably dating myself with that old Saturday Night Live clip, but that's basically what I feel like when I almost feel betrayed when I have to start looking at this kind of stuff. But so that being said, we'll start with utility scores, which is really the basis of a lot of these determinations. What is a utility score? Basically, a utility score is a way to try to quantify a certain condition or disease state, and it's based primarily on patients' self-directed health-related quality of life. So it doesn't have to do anything to do, for instance, in the spine world with how good your x-ray looks, how pretty your screws look, how good your fusion looks. It's really a completely patient-based quality of life issue. And what's important about that is it makes it transferable across any disease state or condition, really. So it allows for comparison of the impact of various disease states on patients' well-being or health. And of course, it's also adjustable to specific societies, because different societies and cultures, for whatever reason, will have different expectations as far as what their quality of life really means. And traditionally, the numerical value that's assigned to the utility score ranges from 0 to 1, where 1 is a state of perfect health and 0 is basically death. And presumably, there's some degree of correlation with the number, and between 0 and 1, the state of health, where 0.5 in theory would be somewhere halfway between perfect health and death. And of course, there is a possibility of having negative numbers, which is when someone's state of health is so poor that they would rather be dead. How are these measured? Well, measured, of course, that's the devil's in the details, and that's where things get complicated, but there are basically two general methods of measuring this: direct and indirect methods. And so direct methods, without getting too much into the statistical aspect, there are two techniques. Standard Gamble technique is basically you're in a certain condition or disease state, how much would you risk in order to improve your disease state? So obviously, if you're extremely healthy, you're not going to risk much, and so that's an indication of a very high utility score, whereas if you have a very poor quality of life, you're willing to take substantial risk, and that's an indication of a low utility score. Similar vein, but different technique, is a time-utility trade-off, meaning presuming you have a certain number of years left to live, how many of those years at your current condition would you give up in order to achieve perfect health for the remainder of the years? So obviously, if you're doing okay, even if you're not in perfect health, you're probably not likely to give up too many years, and so if you're not going to give up many years, you probably have a high utility score. If, however, things are so miserable for you that you're willing to essentially give up the majority of the rest of your life for a small period at perfect health, then you're likely to have a very low utility score for your current health status. But much more common methods of evaluating the utility scores are indirect methods. Indirect methods meaning things like questionnaires, various outcomes instruments that can be actually disease-specific as well. For instance, in spine, as you can see, there's actually we have the ability to convert the ODI to a utility score. And so this is a way to basically ask patients questions, take their answers, interpret them, and then translate them to a score as well. And that's the much more common method that's being used. So why are these important? The primary importance is that they help determine the impact of either a condition or the impact of a certain treatment, i.e. how it changes, that treatment or intervention changes the utility on a patient's health-related quality of life. And again, the ability to measure this across various cultures and across various conditions is extremely important. It allows us to compare the impact of diabetes versus arthritis or spine pathology. And in general, what we find when we do that is that spinal disorders actually have higher or equal impact on patients' health-related quality of life to congestive heart failure, COPD, as you can see, lupus, and hip and knee osteoarthritis. When it comes to orthopedic conditions, it appears that spinal disorders are among the worst when it comes to impact, negative impact on quality of life, and the ability to actually change that when you stabilize an unstable spine is one of the highest impacts of any orthopedic treatment as well. And when you look at the broader range of conditions, looking at various chronic disease, the utility scores tend to be highest in the conditions you see here, and some of them will probably be surprising to you. Lowest, not particularly surprising, in these conditions, and spine conditions tend to be somewhere in the middle. So again, utility score is important as a measurement trying to assess the impact of a certain condition. The utility scores are the basis, but we can actually obtain more information by looking now at health-adjusted life years. What are health-adjusted life years? Well, there's really two of them, two main ones that are looked at, the QALY and the DALY. And the QALY is the one that's really the one that's used primarily to look at the benefit or lack thereof of a treatment. And the DALY, which is a disability-adjusted life year versus the quality-adjusted life year, the DALY is actually looked more as a tool to measure, or an instrument to measure the burden of disease. So looking at developing countries or whatever, looking at the effect of a certain disease on health and the longevity of patients. So what it is basically, it's an adjustment of a year in life based on the quality of that life. So the better the quality, the more that the year is worth. And these are extremely important, as you'll see in some of the lectures coming up, particularly the QALYs, in determining how useful our interventions are and how cost-effective our interventions are. If you do what we call a cost-utility analysis here, which looks at the cost per QALY, okay, so a QALY, well, I'll go into it a little bit more. QALY is basically a year of life at a certain quality of life. If you look at the cost per QALY, obviously the higher the cost per QALY, then of course the better the treatment or the better value the patient's receiving. Okay, so how do you calculate QALY? It's actually quite simple. We talked about the utilities before, 0 to 1. So you look at a specific utility, the number of years the patient actually lives at that utility, and you come up with a number. And of course that number is going to change over time. So if someone lives 80 years at a perfect quality of life, well, they have a QALY of 80, right? And if a condition has brought them from, let's say, death to that perfect, because this is a hypothetical situation, death to that perfect state of health for 80 years, well, that's obviously an extremely high impact of that treatment. So basically what you're looking at the area under a curve where you've got utility on one side, which is 0 to 1, the number of years spent at that specific utility, and you look at the area. So in theory, someone who lives 2 years at 0.5, utility 0.5, has the same QALY as someone who lives 1 year in perfect health. And that's where, you know, some of the controversies arise. Is that really a comparable analysis? You know, what is 0.5? Is a year in perfect health really the same as 2 years in a fairly compromised health condition? So there are some controversies involved with the QALYs as far as their validity. The fact that they're not age-weighted as a year, and this is, again, we get into controversial issues. Is a year at age 16 equal the same as a year at age 92? It may or may not, but that's one of the issues that's been brought up as a critique, as questionably effective in acute and traumatic settings. This is more for chronic conditions, really. It's difficult to evaluate a sudden change in health from a QALY standpoint. And so looking at the DALY, what's the DALY? It's essentially, I call it the QALY's evil stepsister, because they sort of, in many ways, they're opposites and they work inversely, right? So you have your quality-adjusted life years here, right? Your disability-adjusted life years here, and as one starts to dip, as the disease burden starts to increase and the QALY starts to go down, well, then the DALY starts to increase. So one of the assessments that needs to be made when you're looking at the DALY is, especially when there's a premature death aspect to it, is you have to actually use actuarial statistical analyses to make assumptions as far as how long that person would have lived. DALY is how many years of life at perfect health have been lost over time, so you have to know what the end point would have been. So how are QALYs being used? I think the most important is as the cost utility assessment. So again, I talked about the price per gain in QALY, and there are some benchmarks that have already been established back as early as the 60s or 70s. It was established in the US that dialysis for end-stage renal disease was thought to be cost effective at a cost of about $50,000 to $60,000 per QALY. The UK NHS system actually has a threshold, I believe it's £28,000 per QALY as well, which comes out to about $47,000 per QALY, not too dissimilar. And one of the key things to realize is because there's a time component to this, because there's a durability component to it, a treatment can be extremely expensive and can result in not a particularly high increase in utility, but can be extremely cost effective if that's maintained over a long period of time, because of course QALY is utility times number of years. So if somebody has a small incremental increase over 50 years, then obviously they can still have a significant cost benefit from that, or significant value from that treatment. Here's just some examples of where certain treatments stand with regard to cost savings. Pneumococcal vaccine basically is a neutral cost situation, bound to screening for colorectal cancer, which is thought to give a value of $13,000 per QALY saved. So what is our society's threshold ratio? I mean, these are the things that people are looking at. How much are we willing to pay to increase for a certain incremental increase in quality of life, or number of years at a certain quality of life? And we don't really know, but it looks like the range is somewhere between the 20 and 100,000 range. Okay, and in general, it's something that tends to be considered cost effective. If the amount spent to gain one QALY is less than 3 times per capita GDP, very cost effective is less than a single per capita GDP. All right, so I'm going to summarize this pretty soon, but when it comes to spine surgery, one of the problems is that you end up in a situation where spine surgery is extremely expensive, right? So it's extremely expensive. Our follow-up on these patients is very short, so we run into that catch-22 of having extremely high costs and very low, at least documented longevity. So that's one of the issues with regard to trying to obtain higher or longer follow-up care. And although QALYs do have significant limitations, you can see here by this graph, which demonstrates the number of times QALYs have been cited, that these are becoming extremely popular and more important when it comes to making healthcare decisions. So the last thing I'm going to discuss is the issue of cost. So obviously, when you're looking at the value of healthcare, you're looking at what is the benefit of a certain intervention or a certain type of care versus what are the costs and the risks, right? So that's basically known as the value equation. And you're looking at the comparative utility analysis, which is what I mentioned before. The amount that you're paying for a certain incremental increase in quality of life over time, so in QALYs. When it comes to calculating costs, however, this isn't quite as simple a concept as you might think, and I think we're probably going to get into this later. You've got direct costs, which are the easiest to calculate, basically how much this treatment really costs, but that becomes a little more complicated if you get into the nitty-gritty. Indirect costs, which are the costs that are peripheral. They're basically any cost that's not direct. For instance, a patient's loss of wages, right? That's a very significant cost of a certain condition or even a potential intervention. And then the total costs include everything: premium payment, tax payments, disability payments that come from taxpayer pool, et cetera. And the important thing here is that the definition of cost depends on whose perspective you're looking at it from, which makes it even more difficult to try to make all these calculations. Hospital administrators, what will they care about? They'll care about what happens during the admission, because that's where they're essentially receiving their income, and they're having to pay out the cost of the hospital for that. They don't really care too much from a cost basis of what happens afterwards. From an insurance standpoint, obviously you're looking at all services rendered, not necessarily just the admission. Then you're looking at patient family issues, which are totally different. Patient's employer, loss of the cost associated with loss of the patient from the workplace, and the cost of society, which can include loss of the patient's contribution to the tax pool because of loss of productivity. Now the need to pay out not only health care expenses, but disability payments to the patient because of their condition. And the patient's essentially gone from being someone who's contributing to the process versus someone who's withdrawing money from the process. And so anyways, that's just basically to emphasize that there are a lot of complexities in determining the cost aspect of this, which is obviously vital to determining the value aspect of it. So just to conclude and And once again, summarize what these terms are. What is the utility of a certain disease state? It's again a numerical value of the desirability of a given healthcare state, and which means, what is my quality of life in my current state? Numerical value from 0 to 1. What's a QALY? It's essentially that numerical value multiplied by the number of years spent in that condition. A daily is basically the opposite of QALY. It's a measure of disease burden. How many years at perfect health have been lost due to a disease state or disease condition? And then the comparative utility assessment is basically cost per incremental gain in QALY, which is extremely important in determining the value of a specific treatment or intervention. And then when looking at costs, it's important to consider direct and indirect costs. So thank you very much for your attention.
We spend a lot of money on healthcare. This is us on the far left. At per capita expenditure in this country of over $8,000 per person, when the median family income is what, about $40,000, $50,000? You do the math, it just doesn't add up very well, and we're way outside of everybody else. And when you look at all these things, Joe talked about a bunch of them. So Bloomberg ranked most efficient healthcare countries in the world. We were 46 of 48, ahead of Serbia and Brazil, the same numbers. And we do the worst on healthcare on a relative cost basis with the worst outcome. When you look at data on spine, this study's been out for a while. So Burke Martin here at the U put this out, a survey of 45,000 people in a healthcare survey. And they were looking at people's spine problems for how much they were spending and how well they were doing. And like it or not, this is what the data is. There are reasons for it, but this is what the data comes out as. Expenditures for people's spine problems increased substantially from 97 to 2005. We spent a lot more money. As a society, we didn't get a lot for it, though. The proportion of people with functionally limiting back and neck problems increased from 20 to 25%. And mental health, physical function, work, and social limitations for those with spine problems were worse. So this may be a matter of what we're measuring and what we're treating. We might be treating what we're measuring, or vice versa. So, as Mike just said, value is cost over quality. But this is really tricky, right? So not just what are the costs, but whose cost, right? Whose money are we talking about, right? That very much changes how you look at this equation. When you look at quality compared to what, right? And by whom? Whose opinion of quality, right? This is where things vary. So I guarantee you the payers and the patient and the hospital do not view any of these things the same. I didn't even put us up there. We don't view it like any of them. Right, so we start talking about absolute numbers and things. It's very difficult to do because all these things are variable depending who you're talking to. And how do you measure value, right? Cost over quality. What is that? It's really hard to pin down. You can do this a couple of ways. You can do it by the procedure, right? So you can look at QALYs for a discectomy or for an epidural and say, what are the cost per QALY I'm getting for this one procedure? Which sort of helps you, but there are a lot of problems, a lot of assumptions in how you do that. When you compare two procedures, you get something else. So you could say, what's the incremental cost effectiveness ratio of a discectomy versus epidural steroids? You can get a number. You can take this a step farther and look at things over a population and say, I'm not going to so much worry about all these individual procedures and what people are doing. What I'm really worried about is how my population is doing. And then you get into questions of like surgical versus non-surgical care on the whole, which is a very different perspective. And these numbers all change as you go through that. So when you think about this again, what data is used for these calculations? It really, once again, depends upon who is looking. These things get twisted. So I used to think, when I started in this value stuff a number of years ago looking at stuff, but boy, the more you read, the more you see things are sort of twisted and distorted a bit depending on who is writing and who is talking about it. So if you look at one perspective, this would be things like coverage policies for payers and health technology assessments like we do here in the state. Right, so Joe talked about coverage policy issues. These are usually procedure specific. So we talk about cervical fusion, right? We talk about epidural steroid injections. They're procedure specific. To do these things, you may want comparative effectiveness data. You may want to know how do these things compare to my other choices. And you certainly may want data on utilization, safety, cost, and outcome if you're really going to think about all these things. If you take this to non-operative care, this gets a little tricky. So what is non-operative spine care? First of all, right? This is ginormous if you start listing it. I ran out of room. So you can do activity modification, you can medicate people, you can do manual therapy, you can do modalities of various sorts, you can brace people, you can exercise people, you can inject people, you can manipulate or acupuncture or somatic therapies or send them to Pilates or send them to yoga. You can psychologically assess them, and you can stick them into multidisciplinary pain clinics. And this is a partial list, right? And I'd like to thank Carlo for giving me 15 minutes to go through the whole thing. That was very helpful. If you look at stuff, if you look at non-operative spine care in a whole, a number of things really do sort of seem to be cost effective. It also depends how you look at it. So systematic review of cost effectiveness of guideline endorsed treatments for back pain came out a couple of years ago. And they really found, looking at 26 different articles, that a number of things in non-operative care were clearly cost effective for back pain. Interdisciplinary rehab, which has been shown in multiple studies to be highly cost effective actually. Exercise, acupuncture, spinal manipulation, and cognitive behavioral therapy, all very helpful and from a cost effectiveness standpoint when looked at in this light. If you dig a little deeper in the literature, you can start finding all sorts of things on an individual basis. So this study says yoga for chronic low back pain is cost effective. The study by Lynn found yoga was not cost effective, but this one found it was. This is where you start getting to how we calculate value and how we look at these things. So in this study, yoga is compared to usual care, which in the non-operative world means you compared it to nothing, like hitting somebody with a rock is basically usual care. So if you're better than hitting somebody with a rock, your treatment works. And almost everything you do to low back pain patients seems to work when compared to that. So this gets a little questionable. A couple years ago, Mike Lee and I, with some other folks, went looking to sort of try and take this a step further and say, okay, we won't just look at something compared to nothing. We'll look at something compared to something else that might work. So comparative effectiveness, not just an individual treatment. This got really tricky. We tried finding data on studies looking at exercise versus manipulation versus acupuncture, any combination of those. Were people comparing one to the other? And we found a very low level of evidence on pain and function. We basically had 2 studies. So out of the gazillions of studies on low back pain, we had 2 that actually did this. And they sort of made it a wash, right? But there are a lot of details about this and why this may or may not be important. And all we found evidence on was exercise and manipulation. It seemed relatively equivalent. But again, very low level of evidence. We had very weak recommendations in this regard in the paper. And really we found almost nothing on cost effectiveness, which makes it very difficult. If you look at other things, you can start seeing how this stuff gets spun a bit. So this is a study on epidural steroid injections in England. And they tried to look at the cost effectiveness of them within the sort of British healthcare service, right? And what they found is they were cost effective depending upon how much you charged for them, right? So if you just charge one fee that they had, said, well, if you get it at this, then it's cost effective. If you actually charge what people charged for a full day stay to do this, which they didn't think they had to do, then it's not cost effective. So it depends which way you read that paper. This study by Karppinen from 2001 was a study on transfemoral epidural steroid injections. And they said epidurals may or may not be cost effective depending upon the type of disc herniation. What is the pathology you're treating? That may change it. So how much you pay, what you're treating, these things seem to make a big difference in terms of how you read the data. This study I thought was interesting. It's a bit of a twist, but it's a study on cost effectiveness of total disc replacement versus multidisciplinary rehab. What's really curious here is that when they used an EQ5D as their outcome, they said it was cost effective. When they used the SF6D, they said it wasn't. So again, which line do you pick? Who do you believe? What are you measuring? Which of these measures really measures what you want to measure? And this goes back to who you are. Are you the payer? Are you the doctor? Are you the patient? Are you the hospital? And how do you use this data then? So this study I thought was interesting. It sort of shows up, again, a lot of the difficulties in dealing with value, especially in all phases. So Cohen et al. Did a study on radiofrequency neurotomy for low back pain. So this is for facet disease in the low back. And they had 3 different groups in this study. And what they did is they had 3 different treatment paradigms. And they looked to find the final cost per successful treatment in that group. So the first group, they said, you have back pain, it might be your joint, we're going to do a neurotomy. This is not the standard of care for those of you who don't do this. Usually we talk about doing blocks and diagnostic medial branch blocks to sort out who has facet pain and who doesn't. But they just said, well, if we think you have it, we're going to do a neurotomy. And what they found is that in that group, it was about $6,000 per successful patient. If they did 1 medial branch block and wanted 1 medial branch block positive before they did the neurotomy, it was $17,000. If they did 2, it was a little cheaper, $15,000 per success. And the conclusion, of course, was that just going straight to RFN is the most effective most cost-effective treatment paradigm. And as a clinician, this struck me as a little odd because I don't ever really think about doing that. That I just say, you have back pain, we'll go do a neurotomy and sort of fry your medial branch nerves and see what happens to you. It just isn't how I think about things. And there are problems here, and this starts to get into, when you start looking at this data and these numbers of surgical, non-surgical, everything, this is where the problems come, right? This is just emblematic of it. So one, cost. Where did they get the cost data? What is the cost here, actually? You know, in this study, they had cost of procedure and rough estimates for meds and time off of work. They didn't consider other treatments, they didn't consider imaging, they didn't consider all sorts of other things you might actually consider. They assumed no negative effect of the neurotomy. So what if it didn't work? Or what if it went bad? Or what if they had pain for a month? Did that cause a problem? You know, and they didn't say, well, the people who didn't get better, what did you do with them? They didn't factor that in either. So what about people who failed? What about people who got more pain again 3 months later? What did this change? So the time perspective of how you're measuring this value matters. It wasn't blinded, 3-month follow-up, very short. So again, you start going from you have the sentence saying it's cost effective, but then you start looking at the study going, well, this doesn't make a lot of sense to me. I don't think I would do this because of all these things. And they're really not looking at cost utility, which would mean not just how much it costs, but cost per benefit, which is the cost utility side. So in the non-operative world, yes, a lot of things are cost effective. I think the problem we have, and the problem we have with utilization, the problem we have with all this sort of stuff, is that somehow we need to find the right way to do the right thing to the right person. This becomes our trick. It's about patient selection is our whole game. And when you compare something to nothing, it usually looks good because people like having something done to them mostly. But you really start digging through the weeds a bit. You really have to sort out the people who are going to do better with a particular intervention. And it goes, this is from Osler from 100 years ago. It's much more important to know which patient has a disease and which disease the patient has. If we're treating x-rays as opposed to patients, we're not going to do as well. So what I just gave you is a perspective of value if you looked at it from sort of this single episode thing, like a payment, like what regions will cover for lumbar fusion. What if you flipped this whole game around and said, we're not going to look at it this way. We're going to go population-based. We're going to do this on a system. This would be things like an ACO or a bundled care model, which are totally different. This is coverage over a population. This isn't for one person. This is, we now have 10,000 people we're insuring. We want to make sure that we're doing the right thing within that. We're not going to worry so much about what you do with each individual patient, right? When you get this model, several things become crucial. Consistency becomes crucial, right? Doing the same thing to the same patients with a very predictable outcome becomes crucial. And identifying outliers, another point Joe brought up. Outliers become a big deal when you're looking at populations. They account for an enormously disproportionate amount of cost. You also have to really manage your exposure to high-cost interventions. So particularly if the benefit is disproportionate or if there's harm, right? So when you look at a population, you start looking at the data very differently. You start looking at things, again, from more of a 10,000-foot view than in the weeds view. So from that standpoint, you look at non-operative care. This study came out by Fox et al. In 2013. So what they did is they looked at the effect of a required physiatry consult prior to non-urgent surgery consult. I am well aware this kind of policy is wildly unpopular with surgeons, right? I had nothing to do with it, but this is what they studied. You'll see why they studied it, though. This isn't sort of a blanket policy, right? So this is a prospective trial, right? Prospective, and it was really, the doctors didn't do this. This was mandated by the insurer. So doctors didn't set up the trial. The insurer said, we're going to do this. And doctors said, well, we might as well study it and figure out what the hell happens. It wasn't just anywhere either. They didn't pick anywhere. They picked an outlier. They picked a region where it was consistently above the 90th percentile for spine surgery utilization rates. So it's going after outliers, which is very different than everybody. And what they did is they created these sort of centers of excellence, which were put together, had multidisciplinary teams decide what that would be, and they had a physiatrist who was interested in spine care run it, basically. And the only requirement of the program is you had to see a physiatrist prior to a non-urgent visit to a surgeon. If you had a fracture, if you had a tumor, if you had progressive weakness, you went to the surgeon. They didn't stop that at all. And if you went for one visit, you could do whatever you want. That's all they said. And they looked at cost, utilization, and patient experience, and they compared before the program started to the 2 years when the program was running. And what they found was, obviously, the physiatrist had a lot more patients. They're probably pretty happy. So physiatry evals went up 70%, and surgical consults for new patients went down 48%, which is rather striking. Surgical rates decreased by 29%. Interesting, the proportion of fusions went up, and they didn't really get into why. I mean, you could wonder things about, bad things don't get better. The things that really need to be put back together, spondies and things, they don't get better. They're gonna see if that's not, they're gonna get fused. Or maybe discs, if you bought them a little more time, they got through it, I don't know. But they didn't give you an answer. Imaging went down, 18%. And really the numbers of EMGs and the injections didn't change at all. And the number of EMGs were so small, there was nothing significant there about change. When they translated this to money, prior to the program, they were spending $19.77 per member per month on spine care. of which almost $10 was for surgical cost alone. This is per member across their entire population. Again, this is a population-based approach. After the program, it went down to $17.37 per member and $7.29 for surgery. What does this translate to? 12% reduction in total spine care cost, 25% reduction in surgery cost, even though the individual surgeries went up, and it saved them a lot of money, more than $14 million in 1 year for doing this. So like it or not, they're taking a different perspective. They're not fighting in the weeds. They're saying, we're going to take a bird's eye view and see if we can change this and address outliers. And that's what this study is. It's addressing outliers. And if you think about this, well, you know, okay, fine, they're outliers. This isn't going to affect me. I wouldn't be quite so sure about that. So coordinated care delivery systems, what's happening? Where are we going in healthcare? This is where we're going. We're going to coordinated system-based things. We're being driven into clusters as opposed to staying independent. Value-based purchasing, evidence-based care, and a lot of this comes down to the risk is shifting from the payers to providers. I said earlier on, whose money are you playing with? Whose cost is this? Is this the insurer's money? Or is this your money? Is this your patient's money? That all changes these equations very much, right? So the idea being to control cost and change the incentive structure so that doctors and providers follow guidelines and enhance systemic efficiency, and the hospitals become more efficient, not just us, it's everybody. And if you look at the Affordable Care Act, which is what shut down our government recently, there's an article by the authors of that act, Bob Coker and a few others, who wrote most of the language in that act. And this is interesting because it states their intent. This is the intent of the law that is now the law of our country. The economic forces put in motion by this act are likely to lead to vertical organization of providers and accelerate physician employment by hospitals and aggregation into larger physician groups. This is what they're trying to do. They think it's going to do. They're going to drive us into bigger groups that function more efficiently, theoretically. Physicians who effectively collaborate with other providers to improve patient outcomes, the value of medical services, and patient experience will thrive and be the leaders of the system. This is the intent of the law, right? So if you see this happening, it's not by accident. So this data goes back to 2008. These lines continue to diverge when you look at further care. This is a line of medical practices owned by doctors or hospitals. And back in 2008, we crossed a line where now most medical practices are owned by hospitals, not by doctors. And like I said, they're just diverging. The further data just show them, they keep going. So conclusion, value is increasingly important for policy, but is very difficult to pin down. So in the Health Technology Committee, we look at this, but boy, it's really hard to pin it down for just about everything. It's not just spine, it's everything. It's really hard to pin down. Many aspects of non-operative care, when you look at them, are seemingly cost-effective. Compared effectiveness data, we have a lot of trouble. Is it better to do this than that, or this than that versus this? We have trouble with that. We don't have the data. And whatever you think about it, the emergence of system-based care may well substantially alter our perspectives on value and delivery of care, because they may change the paradigm. Whose perspective on quality, whose perspective on cost. That is it. Thank you.
And there's two important questions. Before we talk about the value, we really need to understand does surgery work? Because as we heard, there are people who are saying that there's no value to surgery, so why pay for it in the first place? And I'll talk about that a little bit. But the better question that I'll address in this talk is, do new treatments necessarily require higher cost? Historically, medical advances just about always did result in higher costs to all parties involved, to patients, the hospitals, payers, insurance companies, or combinations. Particularly when you're talking about new technology, and particularly new technology in the last 20 years, where novel devices had to go through a very rigorous pre-market approval process, which was very expensive, and industry, in an attempt to recoup some of those costs for its traditional R&D, as well as the regulatory hurdles, increased the cost of their new gimmicks. And so did the introduction of arthroplasty in specific result in increased cost? And that's what I'll spend a good deal talking to you about. FDA investigational device exemption studies are required for pre-market approval of Class 3 or novel devices, devices that haven't been around before the law changed in 1976. And since the mid-90s, these have largely comprised multi-center prospective randomized studies with significant levels of oversight, the ultimate one being Uncle Sam. And generally, patients had to have failed a conservative treatment before they were randomized to one of two surgical arms, where one of the arms was an FDA-approved and proven technology. And the follow-ups for these studies initially were 2 years and then were extended with post-market surveillance to 5 to 7 years. So we've got a lot of data on these new technologies now, both on their outcomes and, as you'll see, on their costs. The one I'm very intimately familiar with is the ProDisc lumbar study, and that study has been looked at very, very carefully and in detail. The 2-year level data, the 2-year data has been published, and the 5-year data has been published. This patient population was 286 patients. You can see there were 75 fusion patients randomized to 161 of the artificial discs. An additional 50 discs were done in a non-randomized training fashion, but were followed in exactly the same way, so that all of these patients were followed out for a minimum 2 years. And I'll expand on this in my talk later when we talk about outcomes. I just wanted to give you an overview as to the value of surgery. You can see the baseline VAS for pain, back pain in patients was quite high, and these patients had to have failed a minimum of 6 months conservative care. The average patient actually had failed 9 months of conservative care, so they entered the randomization process with a VAS between 7 and 8 out of 10. And immediately after surgery, at their first follow-up at 6 weeks, that was cut nearly in half, whether they had a 360 fusion at that single level or arthroplasty. And you can see that this data was tracked out through 5 years, showing maintenance of improvement. So here's good hard data now demonstrating the efficacy of a surgical intervention. Same thing with the Oswestry Disability Index. It's a patient-generated score of how impaired the patient feels. And both groups of patients were significantly impaired, over 60%. Prior to surgery, that dropped to about 50%. And again, it's maintained out for the 5 years of very tight surveillance. So the bullet points for lumbar arthroplasty were, even at 5 years, the follow-up rates were pretty high. All the patients and centers were involved, that the VAS improvements, the ODI improvements remained stable for 5 years. Reoperation rates remained low because we had our arms around both cohorts of patients. And we even were able to look at adjacent level degenerative changes and saw that the arthroplasty group had less changes. And again, I'll expand on this in our later talks. Patient satisfaction remained very high in this group of patients. We saw similar things looking at an overview of cervical arthroplasty, where again, the data has been analyzed and mined and reported in several different aliquots. You can see the neck disability index, the same thing. These patients had failed a minimum of 6 weeks of radiculopathy on conservative care. Immediately after surgery, their neck disability index fell and was maintained. This is out to 7 years. Their VAS for arm pain, which is what drives them to our office in the first place, also fell significantly. And this data helped Dr. Chang, when he went to Washington State, to show that there was some value to surgery. So a good byproduct of these FDA studies has given us the ammunition when silly policies try to get pushed upon us. We now have really good firm data to use to answer back. We looked at range of motion of these patients on digitized films measured by independent radiologists. So we got a lot of data. And again, the cervical patients have very, very high satisfaction rates that remain stable to 7 years. And I'll go into this in more detail later. Reoperation rates were significantly less, and adjacent level degeneration were less. So how about, now that we've seen that the outcomes look good, how about the societal value? If we looked at patients who had functionally disabling single-level lumbar disc disease, were they better with surgery? Yes, they were. Patients with cervical radiculopathy at a single level, failed nonoperative care, were they better with surgery? Yes. So those things were clear. So let's shift over, now that we've answered the first question, to the economic question. And there are about a dozen economic papers in the literature. The problem is they're hard to interpret. There's a kind of a mishmash of data. Most of them measure charges in the perioperative period. So they'll measure charges in a single institution following the patient through surgery. They involve multiple payers, so that, in the same hospital, Blue Cross, Aetna, Cigna may all have very different contracted rates for the exact same service. So it's very hard when you pool all this data together to make sense of it. Many of these studies use the IDE data, which is a sheltered environment. I mean, these are patients who are selected with very strict inclusion-exclusion criteria, very strict age groups. They may not represent real-world patients. And lastly, some of these papers use inappropriate patient populations, such as a Medicare database. The arthroplasty patients are labeled between ages 18 and 60. So the only patients who are under CMS in that group are patients who are on Social Security disability who may have other comorbidities, other reasons they're on disability. They're not, again, reflective of our typical real-world patient. And I'll review some of those papers with you. One of the earliest economic papers, which was published in 2007 by my partner Rick Iyer, looked at single-level arthroplasty versus fusion from the Charité study. And they compared the costs of a single-level arthroplasty to an anterior lumbar fusion with iliac bone graft with BMP and an instrumented PLIF. They didn't have any 360 data in this study. And you can see on the bottom line that arthroplasty compared very well. The only thing that was cheaper was an ALF using the patient's own bone. If you started to dial in more biologic products like Infuse, it was more expensive. And obviously an instrumented PLIF was more expensive because of the hardware. A second study came out the same year from New York City, also now using some of the ProDisc IDE patients, and they looked at the difference between the economics of a 360 fusion and an artificial disc, and they looked at their hospital charges and were able to show significantly less expense for the arthroplasty than the 360 fusion, about $10,000 less. In the two-level arm of the ProDisc study compared to a two-level 360, the differences were not as significant in this small patient sample. In 2008, another university study, this one from Denver by Vic Patel, looked at hospital costs for arthroplasty versus different types of single-level fusions, either TLIFs, ALIFs, 360s, with or without BMP. And they randomly selected 10 patients in each of the groups, tried to age match those patients. And you can see their cost comparison. The lowest line is with BMP. The one above that shows without BMP. And you can see arthroplasty, again, compares very favorably to quite a significant savings looking at the perioperative bubble for these different fusion alternatives. Matt Gornett looked at a workers' comp population, and in the workers' comp patients who were involved with either arthroplasty or fusion, he found that the total disc patients spent fewer days in the hospital, returned to work sooner, settled their claims earlier, had lower disability awards, and had similar total medical charges, but their indirect costs to society were much less, and their direct cost to the workers' comp, who was paying people for time off, was much improved. This was a study that Donna Onmes from Texas Back presented at SAS. And what was unique about this study is that she used the insurance company as the randomizing agent. So these were patients who the surgeons indicated as on-label patients for single-level arthroplasty who were denied that by the insurance company, who said that procedure was experimental and investigational, but did approve fusion. So Donna tracked those 8 patients, matched them with 8 similar patients who had single-level arthroplasty within the same month. So they're exact matches for their dates, all done at the same hospital by the same surgeons. And then she compared the costs, again, from a single institution. And you can see there's a significant difference. The billing and the payments were about 1/3 less for the patients who the insurance company would not allow to have arthroplasty. So in other words, the fusions cost the insurance companies 1/3 more for everything else, all the other variables being the same. So we're kind of like slicing the pie lots of different ways, but each with its own limitations. This is a study that looked at the national revision burden, and they looked at a 24-month nationwide inpatient sample of about 62,000 anterior fusions, and in general found the length of stay shorter for patients who had arthroplasty than fusion. Hospital costs, again, were less for the patients who had arthroplasty. Interesting, this study, the only one in the literature that suggested the revision rate is higher for arthroplasty, but despite that, the overall costs were less because the hospitalization was less and the instrumentation was less. A study out of San Francisco in cervical arthroplasty used the ProDisc-C randomized IDE model, again showing over 10 years that the costs for arthroplasty were less. An earlier study that didn't include reoperation rates suggested the costs were higher, but because the reoperation rate is shown to be significantly less, that's a very high driver for increased costs and increased QALYs later on. If you put that in and track those patients over 10 years, the cost is significantly less. And this is the last paper that I'll show you. This one, actually, we're going to present at CSRS next month. And this is a paper that does something a little bit different. It looks at actual single-payer costs. It looks at the Blue Cross costs for patients who had surgery for single-level disease. And it's a real-world study because it's looking at real-life patients after approval of arthroplasty and compares just what a single payer actually laid out. And the way we have access to this is a couple of years ago, Blue Cross decided to spin off their database as a separate profit center. So for a very large amount of money, they will actually let you ping their database. You have to tell them what you're looking for, and they'll look for you. But it's a lot of patients. There's 110 million covered lives in this database from 2005 to the present. It's every zip code in the United States, and it incorporates all payments that Blue Cross made for patients. So what we asked them to do is find us patients between January 2008 and December 2009 who had single-level cervical pathology by code, who had payments made for at least 6 weeks before that surgical intervention, and then underwent either an ACDF or a disc replacement. And it could have been either a Prestige, a Bryan, or a ProDisc. Those are the 3 discs that were FDA approved at the time. So we tried to mimic the same inclusion criteria that were in the FDA study. We're able to identify this looking at Blue Cross's data by the ICD-9 and CPT codes. So we're working backwards from their payments into their codes to get these patient populations. So you start with 26,000 patients who were treated with for cervical spine codes. And when you exclude patients with prior surgery, with other systemic disease, patients treated non-operatively, patients who had hybrid surgery, multi-level surgery, or prior surgery, so again, the same exclusion criteria as in the FDA study, we're left with 6,600 patients who had ACDFs and 320 patients who had artificial discs. And that's the patient population we looked at for both the 90-day global period for Blue Cross payments and for their total payments for those patients over 2 years, looking specifically at adverse events and reoperations. When we look retrospectively, again, analyze the demographics, there was no big difference in gender distribution. The ages were the same as we saw in our FDA IDE studies. The follow-up rates were 65% at 2 years. Some of the trailing patients, you can see the follow-up rates dropped dramatically, but that's consistent with an insurance company horizon of about 16 to 18 months. They don't really care about us or patients beyond that time because they think those patients will go to another insurance company. So they have a much more limited horizon than we do as clinicians who have to live with people for a long time. And we looked at, again, comorbidities and readmission rates. There was no difference in payments that Blue Cross made between the 2 groups as far as pain complications. You can see there were relatively low numbers, not statistically significant. Any dysphagia complications had disappeared in both groups by 24 months as well. They did have increased payments in the fusion group for mechanical complications, screw dislodgements, other hardware difficulties, and even in medical adverse events. And part of that is I think there are patients who are sicker, have comorbidities, who would have been pre-selected for fusion rather than arthroplasty. So some of that may be a little artificial. Looking at statistics the way insurance companies look at, you can see the incidence of reoperation was twice as much in the ACDFs as in the cervical disc arthroplasty patients. And this, again, runs in parallel to the findings we examined in our IDE data, where we showed multiple of difference in reoperation rates. These were actual reoperations paid for by Blue Cross, and they paid in twice as many patients who had ACDFs. If you look at their costs, and you can see the top line is the index event, even at the time of surgery, the day of surgery, or the hospitalization, which in most cases was one to 2 days, they paid about 10% less. If you look at the 90-day global period, the difference between $22,700 and $25,000 favored the arthroplasty patients. And then at each of the individual time frames, there was less cost actually paid out by Blue Cross for their arthroplasty patients. And if you look at the total cost on the bottom line, you can see it's a very significant difference, about a 15% difference. And this is their own data. And this is a company that took a very long time to decide to approve cervical arthroplasty. And seeing this data evolve may have been one of the factors that convinced them to approve it. This is a way, again, insurance companies look at patient data that we don't, which is cost per patient per month. And you can see that the cost per patient per month out to 3 to 4 years is less for the arthroplasty patient than it is for the fusion patient, the ACDF. If we look at it in a tabular form, you can see the same thing. They actually know to the dollar how much a patient who got an ACDF will cost them per month over the next couple of years. And the same thing with an artificial disc patient. And the difference is significant. So we learned a lot of things. You know, this was outside of an FDA study. This is a real-world single-patient data. We were able to eliminate a lot of the variables, even though this was a retrospective analysis. It was a unique way to look at the way that a large insurance company paid for the care that we provided. We saw that there was a significant decrease in reoperation rate in the arthroplasty patients, that there was lower cost for the arthroplasty patients at the 90 days and even at 2 years. And that ACDF had a higher maintenance cost, that cost per patient per month. So, you know, if you can get the sense, it was hard to do this because as clinicians, usually we start with a patient chart and work forward. Here we're working with, you know, data for payments that had been made, and now we're working backwards. So it's a different way for us to manipulate the data, but it allowed us to get this very surprisingly well-matched set of cohorts and examine what the actual dollar amounts were. If we look at the literature summary, all the reviewed studies show that arthroplasty is at least similar, if not cheaper, than fusion. From our IDE trials, we can see that the arthroplasty patients maintain their clinical outcomes, and we'll go into that a little bit more later. Thank you.
The theme this morning has obviously been looking at cost concerns in medicine, and in spine surgery in particular, we all know that we're under significant and increasing scrutiny. It has to do with the commonality of spine procedures and the cost of spine procedures. As we're looking at medical costs, though, we, as spine surgeons, we have to remember we're competing with our peers in other fields. And as resources are constrained, it's clear that those procedures that offer the best utility for the buck are going to be the procedures that are most likely to survive the coming scrutiny. Concurrent with these concerns about healthcare costs has been ongoing technological development, whether it be in the biologic arena, in arthroplasty, or in minimally invasive spine surgery, with my area of interest. Things continue to evolve. One of those new procedures or newer procedures is minimally invasive TLIF, which I'll talk about this morning. And as a newer procedure, there are few studies that have looked at the midterm outcome of minimally invasive TLIF, and essentially no studies that have looked at long-term outcomes. Based on my clinical experience with these patients over the past 10 years, my clinic experience with minimally invasive TLIF is that these patients, by and large, are some of my happiest patients. The outcomes, at least my bias was that the outcomes were pretty good, and decided to take a look to see if I could verify that there was some long-term utility to the procedure. So in order to qualify for this study, which was a retrospective review of patients where the data had been prospectively collected, patients had to have undergone a single-level minimally invasive TLIF, number one, and then number two, they had to have baseline patient-related outcome measures. And if so, after IRB approval, they were contacted by my research coordinator. If they agreed to participate in the study, then they were sent VAS leg, VAS back, and Oswestry questionnaires. All of these patients, of course, had filled these out at baseline and then during their clinic follow-up. But we were sending these forms out now at 5 years and beyond. We used, as many people do, separate VAS scales for back pain and leg pain. The ODI score scale is here just for reference for those of you who aren't familiar with it. I'm sure most of you are. 0 to 20 on the Oswestry Disability Index is defined as minimal disability. And if you take a normative population, as Jeremy Fairbank has published, a normal Oswestry and an asymptomatic patient population should be slightly over 10 versus 40 to 60, which is in the severe disability range, and 80 to 100 is basically a bed-bound patient. So using the inclusion criteria, my research coordinator identified 53 patients who met the entry criteria, and of those we were able to contact 37. One of the weaknesses of the study is, of course, it's not 90% or plus follow-up. But for those of you who have attempted long-term outcome studies, especially when there's not industry support and a study coordinator from a company coming and following these patients, and often in many of the studies paying the patients to come back for follow-up, when we're following patients that we've taken care of clinically, it's difficult to keep track of them so many years in the future. So 37 out of 53 I thought was reasonable. So I'll go through very briefly what technique these patients underwent to have their minimally invasive TLIF. So they all underwent a single level minimally invasive procedure with an interbody device made of PEEK and percutaneous pedicle fixation. And it's based on the technique that Holly and Schwender and I published in Spine in 2003, basically an oblique muscle splitting approach to perform a TLIF. It's a typical case, a stenosis and spondylolisthesis in patient who has failed nonoperative management. Typical OR setup in a prone position, just like you would for an open case. Instead of a midline incision, though, paraspinous incisions, 3.5 to 4 centimeters off the midline, depending on the girth of the patient. And we judge, since we're making small incisions, we've got to judge their location accurately and do that with small spinal needles. And 1-inch incisions are typically made at those entry sites. And then through those incisions, the first order of business, at least in our hands, is to cannulate the pedicles, which we do utilizing jam-sheety needles, much as you would for vertebroplasty or a transpedicular biopsy. And those needles are placed under fluoroscopic guidance. I won't go through the technique in any more detail. And K-wires were inserted, which maintain your pedicle pilot holes, but let you maximize your real estate. Again, these are small 1-inch incisions, and if you go ahead and put your screws in at this point, you would need actually more exposure to work around the screws. So we choose to put the hardware in later, mainly leave the K-wires in place as a guidance device. Then using a tubular retractor, dilate a paraspinous pathway down to the target, and that small retractor is left in place. I typically use a 22 millimeter retractor for this, adequate room to perform a TLIF. That's what you're looking for, the junction of the inferior articular process and the superior articular process. That's the anatomy you're looking for. Once you've identified the facet joint line, the articular processes and the pars, you're in the right position. And then those of you who do open TLIFs or minimally invasive TLIFs know this well. You've got to disarticulate the facet complex. Essentially, we make a cut at the junction of the lamina and the infraarticular process, a second cut across the pars, which joins that, and then cut across the articular process, the superior articular process from the caudal level adjacent to the caudal pedicle. And this is what we're looking for, that nice window between the traversing root and the exiting root. Not everyone exposes the exiting root. I did in this case, it needed to be decompressed, but I like to at least know where it is so that we can respect it. and then working in that disc, doing your typical interbody preparation, distracting your interbody space. And because we've got so little room there, you'll see in this slide the distractor is in through the tubular retractor over on the right side of the patient. On the left side, I'm placing screws and rods, which I'll ultimately want for fixation, but it also, in this particular technique, helps us maintain that distraction so that we can then remove the interbody distractor and go ahead and do our interbody work. There's a peak cage with bone in it. And always, of course, supplemental bone graft in addition to the interbody cage, and followed by contralateral screw fixation. So done properly, this is what you end up with. Ideally the same thing that you would have done had you opened this patient. And here are follow-up films at 2 years showing that indeed this patient went on to fusion. So we've published the 2-year results and found that we were able to achieve reasonable fusion rates. This has since been validated by a number of other investigators. So at least we appear to be able to achieve reasonable fusions. And then the VAS and Oswestry data showed significant reduction at 2 years in both the visual analog scores for leg and back and also for the Oswestry. And again, others have since published similar studies with similar findings showing reduction at 2 years in VAS and Oswestry with minimally invasive TLIF. So that's good, but the notion here was, well, are these changes sustained? And as we'll talk, the reason that's important is because the value of a procedure, at least to society or to an insurer, to a payer, increases if the benefit of that intervention is sustained, because the costs of any surgery are front-loaded. You spend them up front. So this was the result of the contacting of these patients who were at least 5 years out, relatively evenly split between male and female, substantial age range with a mean of 63. Mean follow-up actually was slightly over 6 years with one patient out to 90 months. And these were all L4-5 or L5S1 cases, mainly spondylolisthesis cases, some degenerative cases. Most of them were unilateral decompressions, a few required bilateral decompression. And so this is the long-term change that we found in ODI. So mean ODI on entry of 53, which is in the severely disabled range, and ODI at a mean of 6 years of 17, which is in the minimal disability range. And VAS back and VAS leg also significant preoperatively, as you can see, and both with sustained reductions at a mean of 6 years. So when you call the literature in spine surgery and look for verification of long-term outcomes almost in any procedure, you find very little data. Some of the best data coming out now is actually coming from the industry-sponsored studies, the IDE studies, because the FDA forces the companies now to watch patients, especially in the arthroplasty studies, for 5 to 7 years. Outside of that arena, there's not so much data. So one of the groups that's done, at least in my opinion, some of the best work looking at fusion outcomes and especially long-term outcomes is the Swedish lumbar spine study group. And Moeller and Hedlund from that group, I referenced their 2000 study here, where they looked at 106 patients with isthmic spondylolisthesis undergoing posterolateral onlay fusion and found significant improvement in those patients that was then sustained at 9 years. And very remarkable, 101 of those patients were followed at 9 years. And they confirmed the durability of posterolateral fusions for spondylolisthesis, but they noted that the disability, the ODI, worsened over time. So there was an increasing deterioration of the benefit with longer terms. Hackenberg reviewed the midterm outcomes of patients who underwent an open TLIF. Again, very little. This is the longest published study of open TLIF that's in the literature. And they looked at their patients up to 46 months, so not quite 4 years. So if you look, for example, across the top line with the ODIs for spondylolisthesis, you see their preoperative scores were a little less than the patients in our study, at least in terms of ODI. And by 12 months and 24 months, the ODI was down into the low 20s. However, at latest follow-up, which wasn't quite 3 years, the ODI was beginning to creep back up into the low 30s. Now, Dr. Bellabarba gave us an excellent overview of healthcare outcome measures, especially as pertains to cost. And so we all learned about quality adjusted life years. And indeed, it's a composite index that can be used to compare various interventions. So you can take the treatment of hypertension with medication, or total hip arthroplasty, or coronary bypass grafting, or spinal fusion, and get a broad understanding and a comparative understanding of what the worth of those interventions are to society by looking at the QALYs that result. Now, the QALY, remember, is not just the improvement in utility that occurs, but it's multiplied times the duration. So needless to say, the longer your intervention lasts, the higher your QALY is going to be. So there is some QALY data out there in spinal fusion. Steve Glassman's study that he did with Leah Carrion in open posterolateral onlay fusion established a cost per QALY of an open posterolateral onlay single level fusion of around $54,000 per QALY. And more recently, out of Joe's institution, Vandy, Parker et al. Looked at minimally invasive TLIF versus TLIF, and specifically to look at the costs over 2 years of those two procedures. And so if we dig down into that data, relatively small patient cohorts, 15 missed TLIF and 15 open TLIF patients who had similar 2-year improvements in QALY. The missed TLIFs had 0.5 QALY improvement, and the open TLIF is 0.41. The costs of the MIS TLIF in the Vanderbilt Center was slightly less. These are the institutional costs versus the open TLIF. So if we look at the fact that, at least in this study, we found a sustained improvement in the ODI over those at least 6 years following surgery, and presuming that our costs in Memphis are probably pretty similar to the costs in Nashville. Obviously, I don't have that cost data, but I think it's a fairly safe assumption. And the argument would be that this is at least preliminary data to indicate that with the sustained benefit, or the putative sustained benefit of minimally invasive TLIF, that this ought to be a fairly cost-effective intervention as compared to other healthcare interventions. So in conclusion, a minimally invasive TLIF appears to be an effective means to address low back and leg pain, especially in the spondylolisthesis patient population. It's at least equivalent in terms of efficacy to open procedures. This is the first data to indicate that there may be a sustained benefit to the improvement that we see with minimally invasive TLIF. It's got to be corroborated by data from other centers, no question. We need some multi-center trials. But I would implore, especially our younger spine surgeons in the audience, as they're thinking about what to do with their careers, much like Joe talked about his career change from biomechanician to health cost policy analyst. It's a crucial undertaking for us. If spine surgery works as well as many of us believe, it's only going to be sustained if we can prove that utility over time. Thank you very much.
you.